I think as we were discussing earlier, clearly this is the one CSF inhibitor that has shown the true proof of principle activity. I think the other CSF1 receptor inhibitors that we have had commercially available, like imatinib, for example, as you were alluding to earlier, is a pretty potent inhibitor, but the response rates tend to vary, right? They're sort of in the low teens to maybe in the 20–30% range. And I think in all our personal experiences, true volumetric reduction of the soft tissue mass happens very rarely, I guess. I think the tumor may soften up a little bit, the symptoms may get a little better with imatinib, for example, but the true volumetric reduction that then reflects in some of the improvement in PROMIS scores, for example, and the stiffness rating and their mobility of the patient in general seems to be far better with pexidartinib than we were used to seeing with the previous generation of the CSF1 inhibitors. I think nilotinib is another one that has been tested. And again, I think it's a weaker inhibitor of the CSF1 receptor compared to imatinib, as you outlined earlier, and certainly just showed some anecdotal activity. So in that context, I think of the CSF1 receptor inhibitors that we have clinical experience with, and we'll come back to the ongoing clinical trials in a few minutes, this does seem to have definitely encouraging efficacy data. The toxicity profile, I think, generally is manageable, but is definitely going to require some very close monitoring of the liver function tests. The most important feature, though, however, is that since our orthopedic oncology colleagues are the ones who have sort of followed these patients for a long time, they are the ones who are far more attached to the patients. Patients frequently would look at them as the source for guidance as to what should I really do, right? So Drs. Kim and Abraham are recommending no surgery. They're sending them to one of us. We're offering this treatment. And I think the patient may well call the orthopedic surgeon's office back again. So let me bring our orthopedic surgeons back on into the discussion to say, what do you guys think about this drug and the data? Have you had experience? And share some of your thoughts about this drug and this disease. Yeah,
I'll start. So I did the certification for the REMS program and all that required things that were needed in order to be able to prescribe, but I don't plan to prescribe it. It was really just to get a better sense of kind of the disease and the drug and how patients respond. My approach is if I have a patient who I don't think is surgically resectable or is multiply recurrent, I think it is a good idea to put them on the drug, I would then send them to the medical oncologist. But I have gotten that phone call back from the patient and saying, what do you think? Do you think I should go on this, this drug? And, my response is basically that it comes down to balancing the risks and benefits, which is basically, we do think that you'll get symptomatic improvement from being on the drug, but there are some risks and you need to know about what those risks are. So I usually encourage the patients to have, real extensive conversation with the medical oncologist about the risks of being on the drug, and then view that in light of, how bad their symptoms are. I think, just like framing it in the conversation that we had up to this point, it really has been a dramatic change in the landscape of how we treat TSGCT to have pexidartinib be approved. And so, there is some excitement about it, both from the medical oncology perspective and the orthopedic oncology perspective, because these are patients we didn't have anything else to offer. And what we did have to offer, like radiation, for instance, had a multitude of problems. And I've had patients that have been on nilotinib and the other, tyrosine kinase inhibitors. And just like you had mentioned, we may see some symptomatic improvement, but not a significant amount or not enough to make that sort of the leading treatment for this condition. So I don't necessarily encourage patients to take the drug, but I encourage patients to really learn about it and learn about what the side effects are and view that in terms of what their symptoms are, and I let them know that I think it is potentially a good option for somebody in their situation because I've run out of things to do for them. And so now that we have this ability to treat them, then I think there's something they should really consider.
Dr. Kim?
Yeah, the patients do ask us quite a lot. You know, what do you think about the drug and what are the side effects? So I think it behooves us to be very well aware of the kind of the side effect profile and the efficacy data from this drug. For diffuse TSGCT patients, now I always incorporate the discussion of pexidartinib at least into the discussion as a way of at least introducing the idea that we've got this treatment option now is on the table. It may not be necessarily right now that's necessary, but at least if they are well educated on it, when I do send them to medical oncologists, they can have a more fruitful discussion regarding it. It's just not this, oh my gosh, this is a new drug, I don't know anything about it kind of thing. Where I see the discussions trying to occur with this drug is sort of where in the timeline do we do this, use the drug? And is surgery necessary with the drug? Is it not? Is it a drug alone? Because the patients who've been on pexidartinib, I mean, symptomatically are dramatically better. Like they are functioning. And the patients who've been on trial who were like looking at the trial and saying, oh my gosh, the trial's ending soon. I mean, they had genuine fear that they weren't going to get the drug. So clearly it makes a huge difference in people's lives. I think the question really will be is, if you use the drug, where does surgery kind of play into it? Where does that treatment paradigm fit?
And in many ways, I think everybody on the panel also treats giant cell tumors of bone. And there is a really interesting parallel here between both these tumor types where there are drugs that do work. They do cause or induce improvement in symptoms. But the unanswered questions as of yet that hopefully we will be able to with a little extra passage of time is, how long do they continue the drug? What happens if they stop the drug? Like you mentioned, is there some consolidative surgical procedure that is necessary, or is the durability of the benefit long enough and it scars things out that you don't need to go back to the drug, right? I think so. There are plenty of unanswered questions that the trial hadn't addressed, but I think the phase 4 post-marketing experience will clearly help us address over a longer period of time. But I think a fair statement, as you all summarized, is that for the patient with inoperable or for whom surgery is not a good idea, with diffuse disease who is symptomatic and suffering, we do have an option.